Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
Hello, I'm Sam Klempner, a GI medical oncologist at Mass General Brigham Cancer Institute and associate professor here at Harvard Medical School. Welcome to this program entitled Breaking Ground in Gastroesophageal Adenocarcinoma. First line, anti-HER2 therapy for advanced disease. This is part of a 4-part series in which my colleagues, Dr. Jeffrey Koo and Dr. Elena Elimova, and I will take you through a continuing evolution of HER2-targeted therapies for advanced metastatic gastroesophageal adenocarcinomas. I'm going to lead off a little bit with the rationale and the approaches for multiple agents targeting HER2 in this tumor type. Dr. Koo will discuss evidence and current recommendations for treating HER2-positive patients. And then Dr. Elimova will present data for emerging anti-HER2 regimens in the first line. And then finally, we'll bring it all home in part 4, in which Dr. Koo and I will use a case study to illustrate the relevance of everything we've talked about. So hopefully you'll stay with us for the full series. HER2 alterations are a recurrent event in gastroesophageal adenocarcinomas and actually a recurrent event in many solid tumor epithelial cancers. HER2 is a transmembrane receptor tyrosine kinase encoded by the ERBB2 gene on chromosome 17. This is a member of a 4-member family, HER1, which is also known better as EGFR, HER3, and HER4. HER2 is a little bit interesting in that it lacks the ligand binding site and functions mainly through heterodimerization with HER1 and HER3. And when overexpressed in high amounts, can conduct homodimerization, so HER2 receptors homodimerizing. After dimerization, you all remember this autophosphorylation cascade, which is the initial signal that gets transduced through multiple nodes, primarily via the MAP kinase pathway or the PI3 kinase pathway. And this activation has ultimately many downstream effects after reaching the nucleus that include upregulation of metastatic programs, migratory programs, proliferation, cell growth. So about 20% of gastric and GE junction and esophageal adenocarcinomas are HER2 overexpressing or amplified. The rates of HER2 overexpression and amplification tend to be higher in the proximal stomach, GE junction, and distal esophagus, and lower in the distal stomach for reasons that we don't totally understand. The prognostic implications of this are debatable as an independent prognostic variable, but certainly we do know that because of advances in HER2-directed therapy, we have significantly improved progression-free and overall survival for this patient population. There's really 2 approaches that are validated in phase 3 trials in the clinic for our patients, and this is primarily monoclonal antibodies, trastuzumab, and antibody-drug conjugates. In the U.S., this is trastuzumab deruxtecan, and in China, there is another agent as well. I'm going to start out talking about the first approved agent, which is trastuzumab. We've had this drug for over a decade now. Trastuzumab is a monoclonal antibody that binds to HER2 extracellular subdomain 4. And this binding promotes receptor internalization and degradation, so fewer receptors. There is also a recruitment of immune modulatory mechanisms through ADCC and CDCC. And then there is a direct signaling inhibition via binding of trastuzumab to HER2. The effects on homo and heterodimerization are a little bit less well studied, but again, there is intracellular inhibition, albeit a little bit weaker. HLX22 is another novel monoclonal antibody, and this is primarily being developed in China, but is also the subject of an ongoing global phase 3 clinical trial. This also binds to extracellular subdomain 4, but at a different epitope than trastuzumab. And this is interesting because it allows one to think about combinations with trastuzumab or other agents that bind the trastuzumab epitope specifically. And in fact, that is the structure of the clinical trial, is that chemotherapy combination with trastuzumab and HLX22, potentially exerting some synergy or cooperativity between these two HER2-directed monoclonal antibodies. If we move on to ADCs, and I think everybody has seen some version of a mechanistic graphic for antibody-drug conjugates at this point, but trastuzumab deruxtecan, or TDXD, is essentially trastuzumab monoclonal antibody background that via a cleavable linker carries a topoisomerase payload at a drug-antibody ratio of roughly 8:1. Theoretically, what happens is this binds to HER2, is internalized, in the lysosome the linker is cleaved and the payload is released, and this results in high intracellular concentrations of a potent cytotoxic topo-1 payload, exatecan, exerting the cell-killing effect. Also, there is a known bystander effect, which may help address some issues of HER2 expression heterogeneity, which is a well-established feature of gastric and esophageal adenocarcinomas. Disitamab vedotin is another similar concept to trastuzumab deruxtecan and also a very potent antibody-drug conjugate. The monoclonal antibody here is hertuzumab, and the payload here is MMAE. So this is a microtubule agent as opposed to TDXD, which carries a topo-1 payload. So two effective ADCs with slightly different antibodies and quite different payloads. Moving on to some of the more novel agents, zanidatamab is a HER2 biparatropic bispecific antibody. So this is a very interesting drug and probably the first of what I expect will be multiple agents adopting a similar way of targeting receptor tyrosine kinases. So this is an asymmetric structure that binds extracellular domain 2 and 4 of HER2. So essentially the same targets as pertuzumab and trastuzumab, but on a single molecule. Similarly, there is a drug known as anbinitamab, also known previously as KN026 and published in a phase 1 trial. And this is also a novel biparatopic bispecific antibody against HER2. Again, two non-overlapping epitopes on the receptor tyrosine kinase. And this creates a cross-linking and also a sort of daisy chaining of the receptors at the cell surface, which drives some quite interesting mechanisms, including, of course, internalization, similar to what we discussed with monoclonal antibodies. There is a more potent inhibition of HER2 signaling. There is a rather strong induction of ADCC, so some of the similar conceptual mechanisms of trastuzumab. This has been shown to inhibit growth and inhibit dimerization, which is a little bit more clear than what was shown with trastuzumab. Of course, as we've learned from our lung cancer colleagues, HER2 and EGFR can be potently targeted on the intracellular side with small molecule inhibitors. And one of the more interesting ones is zongertinib, which is a irreversible HER2 tyrosine kinase inhibitor that was recently approved for lung cancer based on some very promising single agent data. This is a covalent, so a permanent binder to the HER2 receptors and spares EGFR wild type. This has demonstrated strong preclinical activity in terms of inhibition of signal transduction and potency and cell activity for the HER2 over other HER family receptors, and is currently in early phase trials in HER2 positive gastroesophageal adenocarcinomas. We don't have time to cover all of the mechanisms and all of the potential agents, but suffice to say that HER2 can be targeted in other ways, including CAR NK cells, for example. There are HER2 specific vaccines. HERVAX has been studied and published on previously. This is a B-cell peptide-based vaccine. And then very interestingly is the whole role of the microenvironment around the tumor, which has been known to be modulated by HER2 inhibition and may also influence the activity of HER2 agents. So an area of active research. Some of these drugs exert an immunomodulatory effect through ADCC and CDC, and this can also translate to interferon gamma and downstream PD-L1 upregulation. So there is a plausible rationale to combine this with immunotherapies, including checkpoint inhibitors like PD-1. However, the proof whether this is cooperative or synergistic remains to be proven, but there is a strong rationale for clinical co-targeting. Thank you all for listening and viewing this and the other segments, and look forward to hearing from everyone about how we did. And thanks again for the time.
Hello, I'm Dr. Jeffrey Koo, an associate attending physician with Memorial Sloan Kettering Cancer Center in New York in the United States. Welcome to the second chapter of this program on the historical evolution of HER2-targeted approaches for advanced or metastatic gastroesophageal adenocarcinoma. In this chapter, I will be reviewing current practices for HER2 testing in GEA, clinical practice guidelines for the treatment of HER2-positive locally advanced or metastatic GEA in the first and second line setting, and pivotal clinical trials that have led to the current treatment recommendations. All patients with newly diagnosed esophageal gastric cancer should be tested for HER2 status, along with PD-L1, which often co-occurs with HER2 positivity, as well as mismatch repair protein /MSI status, and now Claudin 18.2 expression. Immunohistochemistry should be the initial methodology for HER2 assessment. It's important to note that the IHC criteria are different for esophageal gastric cancer than for breast cancer, where staining is much more homogeneous. Therefore, a tumor that's actually HER2 positive in gastric cancer could be interpreted as being negative using breast cancer methodology. As such, it's critically important that a pathologist who is familiar with the criteria for staining in gastric cancer examine these slides. In terms of testing, the algorithm that I mentioned is based on the College of American Pathology as well as ASCO guidelines, which is a hierarchical testing starting again with IHC. If tumors are IHC 3+, that's considered a positive result and no additional testing is needed. On the other hand, if a tumor is 0 to 1+, that's also flatly negative and no additional testing is needed as well. FISH testing is required if it's an intermediate result IHC 2+. Based on current guidelines, tumors that are IHC 3+ or IHC 2+ and FISH positive are eligible for HER2-directed therapy. In addition to the use of IHC and reflexive FISH, next-generation sequencing may also be used if there's insufficient tissue, but keep in mind that the sensitivity of next-generation sequencing is less than that of FISH, for example. In terms of first-line therapy, national and international guidelines now recommend that for a HER2-positive tumor that is PD-L1 negative, treatment alone should consist of doublet chemotherapy with trastuzumab. On the other hand, for tumors that are PD-L1 positive with a CPS as 1 or more, it's doublet chemotherapy plus trastuzumab plus pembrolizumab. The basis for these recommendations come originally from the TOGA study, which added trastuzumab to doublet chemotherapy. It was the first randomized study in gastric cancer that revealed a benefit for a targeted therapy in tumors that would IHC 3+ or IHC 2+ and FISH positive median overall survival was 16 months versus 11.8 months in the control arm. That translated to a hazard ratio of 0.65, and that firmly established this new standard of care. The current standard of care was established by the Keynote 811 study, which added pembrolizumab to the combination of trastuzumab and chemotherapy. The study had dual primary endpoints of overall survival as well as progression-free survival. In the final analysis of overall survival and progression-free survival, we also, of course, see clear improvements in the intention to treat population. The survival benefit is restricted only to tumors that are PD-L1 positive, where the CPS is 1 or more. In the CPS 1 or more population, the hazard ratio for progression-free survival is 0.72. The hazard ratio for overall survival is 0.79. However, in the PD-L1 CPS less than 1 population, hazard ratio for progression-free survival is 0.99, and the hazard ratio for overall survival is actually numerically higher than 1. It's 1.10. This suggests that there is no benefit in the PD-L1 negative population. Toxicities that were seen on Keynote 811 were thankfully consistent with the known toxicities of all of the various constituents. In other words, the addition of pembrolizumab did not introduce synergistic toxicity, but we must all, of course, contend with standard immune-related toxicities. While this was a positive study in the first-line setting, there actually have been multiple other negative studies that followed between TOGA and Keynote 811. One that's certainly worth mentioning is the JACOB study, and this is a study that added pertuzumab, so an antibody that binds to a different epitope of HER2, to trastuzumab and chemotherapy. The results suggest that response rates and progression-free survival were improved in the pertuzumab-containing arm. The median overall survival was also numerically better, but the p-value was not statistically significant. I would consider this to be a near miss. There are certainly other flatly negative studies that were also conducted in this space. One of them was the Heloise study, which evaluated the idea of a higher dose of trastuzumab that was not beneficial. Lapatinib, which is a tyrosine kinase inhibitor against HER2, has also been looked at in a first-line study as well as a second-line study, both of which were negative. In the second line, there was a study called GATSB, which compared paclitaxel with TDM1, which is a HER2 antibody-drug conjugate, and that was negative. And there was also a study in Japan called T-ACT. Patients received paclitaxel with trastuzumab versus paclitaxel alone. This was also a negative study and suggests that this is not a beneficial strategy. Why are some of these studies negative? Again, I consider JACOB to have been a near miss. If it had enrolled more patients, it would probably have been powered to detect an overall survival improvement. I think the reason for the other negative studies is that potentially TDM1 is not the most potent antibody-drug conjugate. Similarly, lapatinib as a first-generation HER2 TKI may not be as potent as more current and next-generation TKIs. So turning to the second-line setting, we now know that it is important if a patient progresses on first-line trastuzumab-based chemotherapy to biopsy a progressive lesion. As we know from multiple data sets, about 30% of initially HER2-positive tumors can become HER2 negative. So T-DXd is now firmly established as standard second-line treatment based on a number of studies, initially the Destiny Gastric 01 and the Gastric 02 studies, but most recently the Destiny Gastric 04 study. This was a global study that randomized patients with HER2-positive tumors with prior progression on trastuzumab-based therapy to the combination of T-DXd versus ramucirumab and paclitaxel, and T-DXd was superior in terms of response rates and overall survival, leading it to become the new standard of care. In conclusion, in the first-line setting, the standard of care for HER2-positive esophageal gastric cancer is trastuzumab and doublet chemotherapy, with or without pembrolizumab, depending on PD-L1 status. In the second-line setting for tumors that remain HER2-positive, trastuzumab deruxtecan has been established as the current standard of care. However, there remain unmet needs both in the first and second-line setting in terms of continuing to improve outcomes for our patients. And there are certainly novel anti-HER2 therapies which have the potential to change the current standard of care. Thank you.
Hi, I'm Dr. Elena Alamova. I'm an associate professor with the University of Toronto and the head of GI medical oncology at the Princess Margaret Cancer Center in Toronto, Canada. I will be talking about Chapter 3, the era of opportunity in patients with HER2-positive advanced or metastatic gastroesophageal adenocarcinoma. And I'm going to start off by bringing you up to date on the clinical trial data for HER2-targeted therapies in gastroesophageal adenocarcinoma, particularly concentrating on the first-line space. We'll start with the Phase 3 Horizon GEA-01 study, which I presented at GI ASCO this year. And a part of the rationale for this study was a Phase 2 trial, which looked at the combination of zanidatamab with standard of care chemotherapy. This showed very encouraging activity in the first-line setting for HER2-positive gastroesophageal adenocarcinoma, where we observed a response rate of approximately 84% in patients who were confirmed to be centrally HER2-positive. This is the design of Horizon GA01. Patients with unresectable, locally advanced or recurrent or metastatic gastroesophageal adenocarcinoma who were all centrally confirmed to be HER2-positive and had no prior therapy for locally advanced or metastatic disease, but no prior HER2-targeted agents or immunotherapy were allowed in any setting. They were randomized in a 1:1:1 ratio to receive trastuzumab plus chemotherapy, Arm B zanidatamab plus chemotherapy, or Arm C zanidatamab tislelizumab plus chemotherapy. Based on the results of the Phase 2 study, antidiarrheal prophylaxis was given to all patients on zanidatamab-containing arms, and we randomized a total of 914 patients. The chemotherapy could be discontinued after 6 cycles at the discretion of the treating physician, and there was a dual primary endpoint of PFS and OS in this study. In terms of the primary endpoint of PFS per BICR, looking at zanidatamab plus tislelizumab plus chemotherapy and comparing it to trastuzumab plus chemotherapy, we saw a new benchmark in PFS of 12.4 months for zanidatamab containing and tislelizumab containing regimen versus 8.1 months for trastuzumab plus chemotherapy. This was an absolute improvement of more than 4 months and a hazard ratio of 0.63, which was statistically significant. Looking at the primary endpoint of PFS per BICR for zanidatamab plus chemotherapy versus trastuzumab plus chemotherapy, there was again a new benchmark in PFS reached 12.4 versus 8.1 months with a hazard ratio of 0.65 and a p-value which was again statistically significant. But the improvement in PFS was generally consistent across major pre-specified subgroups, with the exception of HER2-IHC2+, which is likely due to the small sample size. The primary endpoint of OS for zanidatamab plus tislelizumab plus chemotherapy versus trastuzumab plus chemotherapy is shown here. And again, we have achieved a new benchmark with a median overall survival in a Phase 3 study, which has surpassed 2 years, at 26.4 months for zanidatamab plus tislelizumab plus chemotherapy and 19.2 months for trastuzumab plus chemotherapy. The hazard ratio at 0.72 and a p-value is statistically significant. Looking at the primary endpoint of overall survival for zanidatamab plus chemotherapy versus trastuzumab plus chemotherapy, at this first interim analysis, there was a trend favoring significance for overall survival of zanidatamab plus chemotherapy with a median overall survival improvement of 5 months, but a p-value which has not reached the pre-specified significance, an overall survival improvement that occurred across the major pre-specified subgroups, which in this case included PD-L1 CAP scores. We see that responses are deeper and more durable in the zanidatamab-containing arms versus the trastuzumab and chemotherapy arm. And what was really striking for me is that the median duration of response for zanidatamab, tislelizumab, and chemotherapy was almost 21 months. So this is quite impressive, not something that we usually see in this disease. The safety profile was generally manageable. We didn't see any unexpected safety signals. And I do want to point out that the duration of treatment for zanidatamab plus tislelizumab plus chemotherapy arm was much longer than for the other 2 arms. Diarrhea was the most common treatment-related adverse event in all treatment arms. It was more common in zanidatamab-containing regimens. However, what surprised me about our study was that the extent and degree of diarrhea we see in the control arm is much higher than previously reported in other Phase 3 studies. When we look at diarrhea, we see that this generally occurs early in treatment and it resolves within 3 weeks. And I just want to point out that very few patients had to discontinue HER2-directed therapies. This would suggest that what we did to modify the treatment regimen allowed these patients to stay on these effective therapies. So what can we conclude? Well, Horizon GA01 is the first phase 3 study in metastatic gastroesophageal adenocarcinoma to demonstrate a median PFS that is greater than a year and a median OS that's greater than 2 years. These findings support zanidatamab plus tislelizumab plus chemotherapy as an important new treatment option for this patient population. I now want to move into discussing other promising HER2-targeted agents. And we all know about T-DXd, which is now approved in second line. So I want to start off by talking about the phase 1b/2 Destiny Gastric 03 study and really zero in on two arms of this study, which are moving forward in development. This study included unresectable, locally advanced or metastatic gastroesophageal adenocarcinoma. In this study, HER2 positivity was allowed to be done per local assessment, and any PD-L1 status patients were included. In particular, we'll be talking about Arm D, which included T-DXd 6.4 mg per kg with 5-FU capecitabine plus pembrolizumab, and Arm F, which included T-DXd at a lower dose, 5.4 mg per kilogram. This is the usual breast dosing, plus 5-FU plus or capecitabine plus pembrolizumab. That the primary endpoint in this study was investigator-assessed overall response rate. These are the best changes in lesion size from baseline at a median follow-up of 7 to 8 months. When you look at these two waterfall plots, you really see that the majority of patients are benefiting at both dose levels. And so this is very encouraging activity. Looking at the overall response rate, there is a higher overall response rate of 75% with the T-DXd 5.4 mg per kg arm. We're seeing encouraging PFSs with a median PFS of 10.3 months for the T-DXd 6.4 mg per kg arm and a median PFS of 9.8 months for the T-DXd 5.4 mg per kg arm. When we look at treatment-related adverse events, I think none of us are surprised to see that there are more grade 3 events at higher doses of T-DXd, so 76.7 versus 34.4. There was also more chances that you would need to discontinue T-DXd at this higher dose, more chance that you need to do dose reductions or delays, and more chances that you would need to discontinue. But the chosen dose based on the results of this study for the phase 3 studies was 5.4 milligrams per kilogram. And that's obviously because of tolerance. Next, I want to move into the phase 2/3 trial of a very promising ADC, Dasatinib vedotin. So this looked at patients in China with locally advanced unresectable or metastatic gastroesophageal adenocarcinoma. They looked at both the HER2 overexpressing cohorts, so what we consider HER2 positive, and then also the HER2 medium to low cohort, so what we would consider to be HER2 negative, but excluding, of course, patients who are IHC 0. So in the first cohort, there was a 1:1:1 randomization to DV plus toripalimab, which is an anti-PD-1 agent, plus Capox, versus DV plus toripalimab plus trastuzumab. And the comparator arm was toripalimab, trastuzumab, and Capox. In the median to low expressing cohort, they had a slightly different regimen. Again, 1:1:1 randomization. There were 2 doses of DV, 2.5 and 2 mg per kilogram. Both were combined with a PD-1 agent, toripalimab, plus Capox. And the comparator arm here was toripalimab plus Capox because obviously in the HER2 low population, we do not use trastuzumab. In each cohort, the primary endpoint was overall response rate. The most promising regimen for the HER2 overexpressing cohort, and these data were presented by Dr. Shen at ASCO as a mini oral, were response rate of 82.4% with DV toripalimab plus trastuzumab. And perhaps the most promising regimen in the HER2 median or low cohort with a response rate of 71.4% was DV toripalimab plus Capox at a 2.5 mg per kg dose. The median PFS is also extremely encouraging. It was not reached in either of the DV regimens for the HER2 overexpression cohort. It was 14.1 months in the non-DV regimen. So very promising results in this study too. When we look at the safety of this agent, I found this to be actually quite well tolerated. The major grade 3 events that were observed with the dasatinib vedotin varied, but in general, the most common ones, as we expect with these ADCs, were neutropenias and other cytopenias, followed by GI side effects. So there was a 44.4% rate of diarrhea in one cohort. However, there were lower rates of rash and peripheral neuropathy. And the last, and I think, in my opinion, one of the most promising agents is called HLX22. And this was looked in at a phase 2 study, which included patients with locally advanced or metastatic or unresectable GEA who had no prior systemic therapy. So again, this is a first-line study. These patients were had to be HER2 positive as determined by central review. And they were randomized to HLX22 arm plus trastuzumab biosimilar plus Xelox, or the placebo arm, which was placebo IV, trastuzumab biosimilar, and Xelox. The primary endpoint was PFS and ORR by IRRC. When we look at the outcomes in the study, they're very promising. In particular, when we look at the waterfall plot, we really see that the majority of patients, whether they're on the placebo or HLX22, do seem to respond. What's really impressive to me is the median duration of response was not yet reached in the HLX22 arm versus placebo of 9.7. The median PFS also is not yet reached versus placebo of 8.3. And at 24 months, you see 61.5% patients are on HLX22 versus only 11.4 in the placebo arm. And that's really shown when we look at this PFS curve, compare HLX22 versus the placebo arms, which are clearly separating. So not surprisingly, the median OS was not yet reached for HLX22 versus 22 months for the placebo. I'm always struck when I look at these outcomes in studies done in Asia, because patients in Asia certainly seem to do a lot better than what we achieve in North America. And I think the reasons for this are many. So when we look at the treatment-related adverse events, these are as expected. It's actually fairly well tolerated, particularly zeroing in on the treatment-related grade 3 or greater adverse events. It was 29.0 versus 19.4, compare HLX22 to placebo arm. And looking at the most common adverse events, this is platelet and neutrophil decrease, some incidents of anemia, white count decreases, some AST increases. But again, all of these things are things that we can manage in clinical practice. So when we look at where we're going next, this gives you a summary of that. There are 2 large randomized controlled trials, Artemide Gastric 01 and Destiny Gastric 05, which are both looking at the utility of using T-DXd in the first-line setting. The major difference between these 2 studies is that Artemide Gastric 01 also uses a PD-L1 TIGIT agent, which is called relvegostomig, versus Destiny Gastric 05, which is using an anti-PD-1 pembrolizumab. And I think Destiny Gastric 03 is also interesting because the part 3 and the part 5 of these studies are looking at the combination of T-DXd with volrustomig plus chemotherapy. This is interesting because now we're trying to combine an anti-PD-1 and CTLA-4 agent with chemotherapy and T-DXd. The phase 3 study of HLX22 is going on in China, Japan, EU, US, South America, and Australia. I think this is a very interesting study and an interesting agent. This is combining HLX22 with trastuzumab plus Xelox plus or minus placebo. The comparator arm is trastuzumab Xelox plus pembro. There are dasatinib vedotin trials, which are phase 3 trials in China too, and these are looking at the HER2 low space. And I'm not sure how effective any of these agents will be in the HER2 low space. And that primarily is because of this huge heterogeneity that we see in gastroesophageal cancer, which is different than what we see in breast cancer, for example. So the take-home points are that HER2 remains an important biomarker in gastroesophageal adenocarcinoma. In all patients with advanced or metastatic disease, testing for HER2 amplification or overexpression should be done upfront. The interim analysis of Horizon GA01 showed a first-line treatment with zanidatamab, tislelizumab, and chemotherapy regimen significantly improved PFS and OS when compared with trastuzumab and chemotherapy. in patients with HER2 positive GEA, regardless of PD-L1 status. This was well tolerated with appropriate management of diarrhea, and if approved, will likely become a new standard of care in the first line. Other targeted HER2 regimens which have shown very promising activity in the first line setting. But we do have to wait for more mature results from ongoing phase 3 studies prior to determining their role in clinical practice. I'd just like to thank you for your time, and could you please continue on to the next chapter?
Hello, I'm Sam Klempner, a GI medical oncologist at Mass General in Boston, and welcome here to Chapter 4. This is the last chapter in the series, and I'll be talking to a friend and colleague, Dr. Jeff Koo, who's an associate attending at Memorial Sloan Kettering Cancer Center in New York, and we'll be talking about a patient with newly diagnosed gastroesophageal adenocarcinoma. Really, the case here is intended to bring together the prior 3 chapters and the learnings about the recent data that has just been presented regarding some novel HER2 therapies. Jeff, why don't you go ahead and tell us about this case to start synthesizing this data?
Yeah, thanks, Sam. It's great to be with you. So this is a patient that I treated several years ago. So he's a 70-year-old man who lives at home with his wife, and actually, despite his age, continues to work full-time as a stonemason. And he initially presented with about 6 weeks of worsening dysphagia and reflux symptoms, and actually over this period of time had lost 20 pounds, but despite that was still working. His past medical history really was unremarkable, and his social history was notable only for a 5-pack year tobacco history, but he quit in the 1980s, and he rarely drank alcohol. His only surgery was bilateral inguinal hernia repair. At the time I met with him, the only medications he was on were pantoprazole as well as vitamin D. So in terms of his workup, he of course underwent an endoscopy because of these symptoms, and that revealed a tumor at the GE junction, and biopsy confirmed a moderately differentiated adenocarcinoma. He then had a CT of the chest, abdomen, and pelvis, which showed thickening of the GE junction. There were periesophageal lymph nodes up to 2 centimeters in size, as well as several liver lesions up to 3 to 4 centimeters, which were radiographically consistent with metastatic disease.
Yep, sounds like a typical patient in both of our clinics and a candidate for therapy, which is great. The biomarker landscape, of course, continues to evolve, but maybe talk a little bit about the testing you guys did and why it's important.
Yeah, so there are 4 things really that we should test for today in early 2026, and that's HER2, mismatch repair proteins, PD-L1 status, as well as Claudin 18.2. And that represents really the totality of standard of care biomarker testing at this time. So indeed, we tested for all of these proteins, and his cancer cells were HER2 IHC3+. They were MMR proficient. PD-L1 CPS was 10, and Claudin 18.2 status was about 40%. So in addition to that, we also did next-generation sequencing. These results, of course, don't come back initially, but ultimately they did reveal that there was also ERBB2 amplification, as well as several other mutations and copy number alterations, none of which were actionable. Next-gen sequencing confirmed this was an MSS tumor, and the TMB was about 4 mutations per megabase.
Yeah, typical comprehensive testing from a very good cancer center. Maybe expand a little bit on the HER2 testing. Are you more enthusiastic when you see a 3+ versus a 2+ FISH positive? Does the concurrent amplification make sense, reassuringly, etc.?
Yeah, I think in your question is the answer. So absolutely, I think the contemporary definition of HER2 is of course IHC3+ or IHC2+ and FISH positive. It is worth mentioning that testing should be sequential, so all patients should start with IHC, which is a quick, cheap, reliable test with a short turnaround. And if it's IHC3+, that's by definition HER2 positive, and you don't need FISH. If it's IHC 0 or 1+, that's negative, and you also don't need FISH. Actually, the only time reflexive FISH should be performed if it's IHC 2+. And as we'll talk about in the current data set with zanidatamab, one of the subgroup analyses does interestingly suggest that maybe the IHC3+ tumors derive more benefit than the IHC2+ FISH positive, although the numbers are small. But certainly, I think to your point, there are now multiple data sets that the more ways we know that a tumor is HER2 positive, the more patients benefit from anti-HER2 therapy. So I think it was also concordant and reassuring that next generation sequencing subsequently revealed HER2 amplification. But I think in terms of standard of care testing, it really should start with IHC and progress to FISH only if there's indeterminate result. Next generation sequencing should not replace standard IHC and FISH for testing, because those actually remain the standard criteria if we were considering clinical trial enrollment.
Yeah, and in a world of increasing availability of agents and maybe needing to know dual biomarkers to select drugs, in a perfect world, would you want the HER2 status from the primary tumor or a liver met?
There clearly can be heterogeneous expression intertumorally, but also intratumorally. So I think ideally you want to try and biopsy as many sites as possible. I think here in this case, since we had a determination that the tumor was HER2 positive in the primary tumor, we didn't proceed with a liver biopsy. The CAT scan was radiographically consistent. So all of these things being equal, in this situation, I typically don't mandate a biopsy. I would typically consider a biopsy only if there is some kind of atypical or discordant response to first-line treatment. And there have been rare instances where a primary tumor is HER2 negative, but a metastasis is subsequently HER2 positive. So certainly, I think it would also be absolutely appropriate to biopsy an easily accessible metastatic site.
And then maybe a little bit about the distribution of IHC 3 plus versus 2 plus, as well as the distribution of PD-L1 within the HER2 positive patients. How often are they positive?
We know from Keynote 811, and we know now from the Horizon GA01 study, that approximately 80 to 85% of tumors are IHC 3 plus. With Keynote 811, about, again, 80 to 85% of tumors had a PD-L1 CPS of 1 or more. On the other hand, we actually found that in the Horizon GA01 study, only about 60% of tumors were PD-L1 positive using that scoring criterion.
So tell us sort of what you did do with this HER2 and strongly PD-L1 positive patient.
At the time, the patient did end up receiving pembrolizumab, trastuzumab, and chemotherapy. Did well for some period of time, but did eventually progress, I think, around month 8. But clearly initially had significant clinical improvement. His dysphagia resolved. He regained his weight. He was able to continue working. Nice partial response in imaging for the first several CT scans.
I think that's generally been my experience as well with these patients who fit that profile that you described. I want to get a little bit into the zanidatamab data, which of course you've been participating in for a long time, and Dr. Elimova just presented. Not to rehash the data completely, as chapter 3 really covers that, but a very practical point or question first, because it's probably going to come up. Let's say your patient was CPS of 2. Do you feel like if the Zani data is based on TAP that you need to retest this patient? You're comfortable calling them PD-L1 positive? Or maybe it doesn't matter for the Zani data either?
The CPS score is actually highly concordant with TAP. There are 2 different methodologies using 2 different antibodies, but broadly speaking, there is concordance. And in fact, we know from the FDA approval in the first-line setting for HER2 negative disease of tislelizumab, pembrolizumab, and nivolumab, all of these just require PD-L1 positivity. The scoring system and the antibody actually is not specified, which suggests that even at that level, we think that these scoring systems are comparable. So I would broadly interpret a PD-L1 CPS2 tumor or a tumor with a TAP of 2% as being PD-L1 positive. But I think you raise an excellent point as we're all digesting the data. To me, actually, one of the pleasantly surprising findings from the GA01 study was that all patients seemed to benefit irrespective of PD-L1 positivity. Whether it was a TAP score of less than 1% or 1% or more. So, I would say as a practical perspective, I don't think pathologists at either of our institutions are going to be quick to jump on the TAP bandwagon. I think from an academic perspective, as long as a validated antibody and validated scoring system is used, that gives us the assessment of PD-L1 status.
Let's say Zani is available to you now and you see this patient tomorrow as a new patient.
So I think certainly if I were to see this patient or a similar patient in clinic, today, I think, clearly the answer would be zanidatamab-based treatment. I think the more complicated question is whether there is a benefit for adding tislelizumab. And I think as we know from Dr. Elimova's presentation of the data, the Arm C versus Arm A overall survival comparison certainly shows that zani-tislelizumab and chemotherapy is superior to trastuzumab and chemotherapy, both in terms of progression-free survival and also overall survival, with something like a 7-month difference in terms of overall survival favoring the zani and tislelizumab arms. Now, at the same time, we also know that at this first interim analysis, the Arm B to Arm A comparison, so zani plus chemo versus tras plus chemo, there is a statistically significant improvement in PFS, but at this time, there is only a strong trend towards improved overall survival, but the p-value is not yet statistically significant. And then finally, I think if we compare Arm C and Arm B, I think that really raises the question is what is the contribution of the tislelizumab? Should we be offering the triplet combination or is zani plus chemo sufficient? One thing that really jumped out at me was that the median duration of response was nearly 21 months for zani plus tislelizumab plus chemotherapy, I think versus something like 14 months for zani plus chemo, which is still very impressive, versus only about 8 months for trastuzumab plus chemotherapy. At this point, the median follow-up is about 2 years. The median overall survival is a little bit more than 2 years. But for me, I'm persuaded by a median duration of response of 21 months. And certainly in patients who are otherwise eligible to receive immunotherapy, I would certainly consider zani, tislelizumab, and chemotherapy.
Yeah, I think very reasonable interpretation. I agree that's hard numbers to ignore. I think the tisli is contributing something, and hopefully time will help resolve that. You have experience with FOLFOX and CAPOX as the chemo backbone. So if all this stuff is available to you as an experienced investigator with both, what are you going to do?
There are multiple data sets that, North American patients probably tolerate CAPOX the worst. They certainly tolerate much worse than East Asians, and actually probably even a little bit worse than Western Europeans. So I certainly hope that we're able to combine it with FOLFOX. And I think to your point, in the phase 2 study that paved the way for this phase 3 study, most patients in the US received FOLFOX. But I think this is also an excellent way to segue into the fact that, so in the phase 2 study, something that surprised all of us was that initially we saw a very high rate of grade 3 diarrhea. In fact, it was about 50% when we gave the zanidatamab and FOLFOX without any modification. So based on that, we omitted the bolus 5-FU from the modified FOLFOX 6. But at the same time, every patient had mandatory loperamide prophylaxis for the first week. And this prophylaxis was carried over into the phase 3 study. So I think something that we absolutely need to be mindful of is that patients, if they're receiving FOLFOX, yes, we should omit the bolus 5-FU, but more importantly, I think they need to be on loperamide for at least a week. And I think at the end of that week, we really need to touch base with them closely. Clearly, if they're obstipated, we can stop the loperamide. But if they're having even grade 1 diarrhea, we should absolutely continue the loperamide. If they're having grade 2 diarrhea, then I think we need to consider other antidiarrheal therapies at that time, even in the phase 3 study, especially in the combination arm with tislelizumab. Zanidatamab had about a 25% grade 3 diarrhea rate.
I think we can all agree that there's probably no difference in the AE profile of TIS versus other PD-1 agents. It's really the zani versus the trastuzumab. So as these patients are on therapy for a long time, maybe just end with how you think about incorporating the patient voice or shared decision-making about length of chemo. How do you guys, when you meet with patients who've been on these regimens for quite a while?
20 to 25% grade 3 diarrhea rate is something that all of us are simultaneously aware of. So I think that's certainly a critical part of the decision-making with patients. In my experience, most patients would accept the increased toxicity for clear benefits or clear superiority. But I think that is an absolutely critical decision. And of course, there are very specific patient characteristics that determine whether zanidatamab is an option. I think, for example, someone with inflammatory bowel disease, someone with an ileostomy, someone with short gut syndrome, someone who already has very irregular bowel movements at baseline, potentially there are relative to absolute contraindications. I think maybe to answer the other part of your question, so the GA01 study did allow for all chemotherapy to be discontinued after 6 cycles or 18 weeks. Certainly, I think that would be a consideration depending on how patients are doing. So we actually know from the zanidatamab monotherapy data that the incidence of grade 3 diarrhea is very, very low. Most diarrhea is grade 1 and 2 and much more manageable. So I think in a patient who has ongoing diarrhea that's affecting their quality of life, and especially if they have great disease control and response, discontinuing all chemotherapy, but especially the fluoropyrimidine, which really seems to be the additive or synergistic drug that's causing the diarrhea toxicity, I think actually it's a strong consideration. But I think as all of us become more and more familiar with the regimen, I think the comfort level with discontinuing all cytotoxic chemotherapy, which I'm generally not comfortable with, I think that's something that we'll have more experience with.
Yeah, I agree. I think that's a great way to bring it home. I think this is going to be the benchmark that ongoing frontline trials are sort of going to be held to as the data continues to emerge. I want to thank you, Jeff, for making some time, and thank all the listeners and observers for participating. Please continue to answer some of the questions and evaluate us. And thanks again.